Hello, I'm Captain Monica Lukendorf, and today we're going to be going over my tech talk on procedure simulators in obstetrics and gynecology. I am a maternal fetal medicine physician currently stationed at the Uniformed Services University of the Health Sciences. I have no conflicts of interest to disclose, and these are my own views. They do not represent any official views of the United States military or the federal government. I will be talking about different available procedurals and virtual reality simulators today, and discussion or mention of trade names or companies does not imply endorsement by the federal government. These are our learning objectives. Our goals are to be able to describe some of the different procedural simulators that are available in obstetrics and gynecology, to identify opportunities to use procedural simulators for process improvement and monitoring, and to consider future changes and uses of procedural simulators. And finally, to integrate procedural simulators in training and practice. So a little bit of background. Medical simulation is kind of based on a lot of the flight simulators that were developed in the early 1920s and 1940s. And shown here is a picture of the Link trainer, which was an airplane cockpit that replicated all of the instruments and controls that were needed to fly the plane. So this is kind of what prompted a lot of the medical simulation that we see today. This ability to fully replicate and do procedures is similar to fully replicating and flying a plane and an aircraft. In terms of procedural skills assessment, there are many different options shown on the left and many potential cases, particularly in obstetrics and gynecology. So some of the different simulators that are available include things like animal and human cadaver simulators. These are obviously quite realistic, being that they're using actual tissue, but certainly can have cost and ethical considerations. There are many high fidelity trainers that are on the market. We'll go over a few of the different options that are available. Certainly, these can carry a high price tag and may not be entirely necessary based on what you're trying to train or achieve. And then there are many low fidelity trainers. So this includes things like box trainers and different components that can be used in a more realistic setting or specifically to teach different skills. And then there's virtual reality simulators. These can be very effective and very realistic in training. The other consideration is really where you're going to do the training. Are you going to do this in a simulation lab or a simulated operating room, or are you going to do this in situ? Are you going to train actually on labor and delivery with your team, with your equipment, and can you then test systems and processes? And finally, the use of standardized patients or Confederate actors. This can be a very effective incorporation in the simulated setting and certainly something that we use quite frequently with our medical students. In terms of the potential cases where we can use procedural skills assessment in obstetrics and gynecology, there are many. This is a fairly comprehensive list, but certainly there are likely some that are not on here. So we'll talk a little bit about options for using this for maternal cardiac arrest, things like ultrasound and amniocentesis procedures. We'll talk about surgical simulation, including hysterectomy, laparoscopic surgery, vaginal surgery, and then using it for deliveries. So vaginal delivery, operative vaginal deliveries, and then any of the many obstetric emergencies that can occur. So things like shoulder dystocia, operative vaginal delivery, postpartum hemorrhage, breech delivery, and cesarean delivery. So I think when you consider the different training opportunities that you're going to encounter, either as an educator or a clinician, you want to think about what you're trying to teach. Are you trying to teach procedural skills, in which case a task trainer may be adequate? Are you looking at things like leadership, how people lead a team, how they organize and how how they lead under pressure or stress, then you may have a different setup or a different plan in place. One thing that's really important, I think, to consider is communication. So, as we know, up to 70% or more of patient safety events involve lapses in communication. And this can be one of the more challenging things for even seasoned clinicians to do well in. So, I think communication is another training opportunity to consider when you're planning ahead. And then what about team dynamics? Are the teams under stress? Are they always the same team, or do you have rotating teams with similar people, but it could be really anyone on the team that they're working with? And how do you organize a team and get things accomplished in an effective and efficient fashion? So thinking about that as a potential training opportunity. And then what are the systems and processes that you may wish to evaluate and improve? Certainly, as we mentioned, doing in situ simulation has some benefits in terms of being able to use your actual systems and processes. But then you also need to consider the impact on the team. You might need to consider the impact on the team and how best to coordinate and get resources effectively to the patient. Great examples of this include the use of the massive transfusion protocol, which can require a series of steps to initiate the protocol and then effectively obtain and then transfuse blood products. So I wanted to speak a little bit about maternal cardiac arrest. Certainly, this is something that we don't counter frequently in obstetrics and gynecology, which also makes it a great opportunity for simulation. So simulation is really especially important, I think, in those really high acuity, low frequency events like maternal cardiac arrest. And so for maternal cardiac arrest, the survival rates in this patient population are upwards of 60%, which is much higher than other cardiac arrest populations. And when we think about maternal cardiac arrest, I'm showing over here on the right-hand side of the screen one of the important components in a pregnant patient who is somewhere between 20 weeks and term is displacement of the gravid uterus. So the gravid uterus, when the mother is in the supine position, can impair venous return to the heart by up to 40 to 50%. Well, if you think about a person who's in cardiac arrest, effective high quality CPR is probably only giving you a circulating volume of about 40 to 50% of cardiac output. So you can very rapidly see if you don't displace the uterus correctly during cardiac arrest, you're probably very ineffective in your chest compressions. And so this is actually a skill that requires not only an additional team member, but coordination for effective accomplishment of successful maternal resuscitation. And so here's an example of two resuscitators providing CPR for a patient. You would essentially need at least a third person to displace the uterus and then probably a fourth person to effectively carry out a resuscitative cesarean delivery or peripartum cesarean delivery. And so I think the important thing here is to really look at newer simulators. Laerdal is developing one that's not yet on the market, but was used in the clinical trial, showing the benefits of maternal cardiac arrest simulation. And this new simulator obviously has a gravid abdomen. It's sort of like the resuscitative Annie mannequin, but has the gravid abdomen with a uterus that can be displaced. And then I think the other critical piece is that this also provides real-time feedback to the team on whether they're effectively displacing the uterus. And so there's a little indicator that shows when you've effectively displaced the uterus. So it really allows you to perfect and improve your skills. So similar to the way that the resuscitative Annie mannequin now provides you feedback on the quality of your chest compressions, you can now combine that with the ability to determine when you're effectively displacing the uterus. So that's another great simulator that will be coming out soon, hopefully. Another opportunity for procedural simulators in obstetrics and gynecology is ultrasound. So this is a skill you can certainly practice in an apprenticeship model on actual patients, and we do some of that. But I think it's kind of nice for students, residents, and people who are learning ultrasound to have additional opportunities, including ultrasound simulators. So I've shown a couple here. On the left is SonoSim, which is an entirely virtual platform. They do have a kind of a gel pad that you can put the simulated probe on. And then they have standardized modules that allow you to kind of go through the different motions of moving your probe around And they have different packages that you can purchase that include modules for obstetrics and gynecology, the emergency department. They have a pretty wide range of applications. The other nice thing is it does include some educational things like background, how to scan, different anatomy that can be correlated with the training sessions. So a really great option. Probably not quite the same hand feel as what is shown over here on the upper right, which is another simulator that allows you to actually scan on a model with different parts on the inside. So that can give you a little bit more of a hand sweep because you're kind of going over the entire abdomen in that simulated model. And then down here on the bottom is another virtual simulator application with a transvaginal probe, which again has some different hand motions. That's also available in the SonoSim module as well. So another opportunity, kind of an extension of the ultrasound simulators, is an amniocentesis procedural simulator. So there are a number on the market, some that you can purchase. The one over here on the left is the Amnio Abbey, which has a full package of a preset kind of black balloon that you fill with fluid, and then you add ultrasound gel and you can overlay a placenta, and then the abdominal skin is shown down in the bottom. And now you can actually use your ultrasound with amniocentesis equipment like a needle and everything to simulate the placement of the needle and watching yourself real time on ultrasound to practice the eye-hand coordination for an amniocentesis procedure. There are a couple of different homemade models that you can use as well, shown over here on the right. This is a pig uterus that you can actually buy, fill the uterus with fluid, and the little preserved pig fetuses kind of look pretty realistic on ultrasound examination. And so once you do that, then you can add the gel and then do your ultrasound right on that. And that can also be used to practice amniocentesis procedures. And then up on the top here is another example of kind of homemade procedure simulator with different balloons inside of a bucket of gel. And that can then be used to ultrasound. A lot of times people will put like ballistic gelatin. You can kind of melt it down into a flat plate and put that over the simulator, and then you can scan on that. So another option here for a task trainer for amniocentesis procedures. So looking a little bit at different surgical simulators, I think we've all probably sutured on some of the different suturing simulators. That's a very basic model that everyone can start to perfect their hand skills for suturing and basic surgical procedures. There are a number of different virtual simulators as well. We'll go into these a little more in detail, covering all different areas, including laparoscopic and robotic surgery that can be implemented. And then this company, VirtuMed, has an entire suite filled with a lot of different OBGYN applications. So for hysterectomy, there are definitely some models that are available. The one on the left here is the operative experience model. This allows for an in situ simulation experience if you wanted to do this in an operating room and test your processes and procedures for a abdominal hysterectomy or cesarean hysterectomy. That's a great model. You can see much of the model is made out of silicone. So the nice thing is sometimes you can actually re-silicone back or glue some of the components back together and reuse them. So that can be a little more cost effective. Otherwise, the inserts can be fairly expensive. I think it's usually around $800 for 2 inserts. And then the model base is around, I think, $10,000 or $15,000. So that can be a bit of an upfront investment, but then the task trainer can be used multiple times, just replacing the insert. It does have the ability for bleeding, so you can have blood, and that can provide a more realistic scenario for participants. I will say the tissue feel is a little bit different since it's silicone. It's a little firmer than what you would normally have for human or cadaveric tissue, but it's certainly a good option to test the process. And it allows you to really go through every step of the simulation, getting all your instruments, making sure your tray is open and counted. So that's a good option as well. And then over here is an example of a virtual reality simulator. So you can see that you're able to simulate a abdominal hysterectomy using a virtual reality simulator as well. So again, some pros and cons of both, but I think definitely options that are available to you as well. And then for laparoscopic simulators, there are definitely a lot of different box trainer things. I know for fundamentals of laparoscopic surgery, they have a box trainer that's available. A lot of these will hook up to a monitor so that you can get a realistic experience looking at the monitor. And then you can practice eye-hand coordination for your laparoscopic procedures. Robotic simulators are very popular as well, and I think particularly helpful for people that are learning to do robotic different procedures in obstetrics and gynecology. There's a couple examples here. You can really get a lot of benefit out of learning how to be on the console, how to dock the console, and how to complete procedures on the robot. So a great opportunity. This is certainly something that can be useful when you're learning a new skill or something that you haven't done in the past. In this case, robotic surgery. This can be a helpful adjunct. There are also vaginal surgery opportunities and task trainers. Here's one called the MIA model, which allows simulation of different vaginal procedures. You can see there are different components that can be used interchangeably to simulate vaginal surgery. Again, a really important part of training and learning new procedures. And then there are a variety of different birthing simulators that can simulate a birthing scenario. You can see up in the upper right-hand corner is an example of a task trainer. This is great for practicing specific procedures. And then there are some more realistic, kind of down in the middle, simulators that would be considered high fidelity with mannequins that can talk and breathe and seize and move. And then there are birthing simulators where these are things that people can wear, and then you can incorporate a patient actor into the scenario. I will say the feedback from participants is generally the wearable ones with a real person interacting tend to be the most realistic from a participant perspective. So some of the task trainers, for example, showing breech vaginal delivery are great. You can use sort of that high fidelity mannequin shown over here on the left to practice a breech vaginal delivery. But if you're really focusing on skills and teamwork, you may only need a task trainer and then be able to either test test the entire system by doing a task trainer in an in situ setting, or just practicing the manual skills and talking through how to proceed can be easily done with a task trainer, and then avoiding the cost. Some of these mannequins can be quite expensive. Shoulder dystocia, again, another great opportunity, can be done with a high fidelity mannequin, but can also be done with a task trainer. So there's a lot of maneuvers that need to happen. Shoulder dystocia is where the anterior shoulder of the baby is typically caught on the pubic symphysis, which is an emergency. They don't happen very frequently, and you only have a couple minutes to relieve them. So it's really important for people to be familiar with the maneuvers, how to properly get your hand into the posterior fossa to do your maneuvers. And so I really think task trainers and simulation are helpful in this setting. There have been randomized controlled trials and studies looking at skill attrition related to shoulder dystocia and have definitely shown a benefit with practicing and shoulder dystocia simulations in improvement in neonatal outcomes. And in fact, many insurance companies will actually give a discount for providers that have completed simulation training because of the benefit. There are also simulators that include a traction device in the fetal shoulder and neck. And then you can actually measure and show people while they're doing the simulation how much traction they're putting on the baby's neck. So again, a really effective way at improving outcomes and improving training in obstetrics and gynecology. Another example of a task trainer or a high fidelity model can be used for operative vaginal delivery. So practicing things like forceps and vacuum. Again, this is a skill that requires practice. They don't happen that often, but when they do, being prepared and knowing how to properly place forceps or vacuum is key in a safe delivery. And so these are other options as well. And then for postpartum hemorrhage, a wide range of options for postpartum hemorrhage simulation, including virtual reality, some task trainers shown here with fake blood. The operative experience trainer also has a model that just does postpartum hemorrhage. So then you can practice clamping things off, doing things like the B Lynch suture, and then some low fidelity options for training. The upper right is a publication we did a couple years back looking at training for the Bacri balloon and for postpartum hemorrhage simulators. And we used a cantaloupe, and you kind of lop the top part off, and then you have a cavity that simulates the uterine cavity. And now you're placing your uterine balloon to tamponade the uterus, and you can actually feel when you have a good seal and a proper fit. So that's another option as well. And then a variety of different simulators for cesarean delivery. This one's an operative experience simulator where you can practice the uterine incision and the fetal delivery, which are great options for both in situ and simulation lab simulations. So in terms of quality improvement and reporting, this is now sort of a requirement by the Joint Commission to not only provide training to people, but also to include multidisciplinary drills. So looking at maternal hemorrhage, it's required to provide role-specific education, and it's essential that everybody understand the procedures and how to function in the event of a maternal hemorrhage. The Joint Commission also requires at least annual drills to determine if there are any system issues as part of management of severe hypertension and preeclampsia, including a team debrief. And so I think these are both opportunities that have been embraced by the Defense Health Agency as best practices. And the DHA does require monthly unit drills for both of these types of emergencies. So what about the future? I think there are definitely going to be continued advances in virtual reality, likely a lot of different AI applications. I think some of the important areas to work on would be to improve some of the variability and access to simulations. So there does seem to be some inequities related to that, mostly simulations available at larger facilities, but I think in smaller places where you're having less volume and less clinical support, simulation becomes almost more important. Simulation certainly is very helpful in learning new procedures and techniques, things like robotic surgery. And then, as I mentioned earlier, reporting on data quality is an important component of this as well, and is something that is required by DHA to report back the findings from the monthly drills. And then it is already required by the Joint Commission for hospital certification, but could also become a more important component in things like board certification in the future moving forward. So I think also thinking about how you can integrate these different procedural simulators with training is important. Every new procedure has a learning curve. And so when you think about interns and residents, they are learning and starting at the beginning. So integrating this into assessing their competency is important. And then maintaining knowledge, skills, and abilities is important for people as they move further into their career. And then we talked a little bit about teamwork and leadership and how best to assess this using procedural simulators. And again, I think this is really important for those rare procedures or emergencies. This is an example of a recently published article by Dr. Greer and colleagues going over an innovative simulation curriculum to train general surgery residents and students on 4 commonly encountered OB/GYN procedures. And so I think this is important too when you have people going to smaller commands. They might be covering things that they think, oh, the GYN doctors have it. Well, maybe not at a smaller command or on deployment. So definitely great opportunities to expand and integrate with training. And then how does this look in international countries? So there a lot of the simulators that Laerdal develops, including the Mom and Natalie, which is the wearable birthing simulator, can be used in developing countries. And that was some of the intent behind why they developed those, since they would be low cost and would be effective in teaching people about how to respond to obstetric emergencies. The picture on the left here is a group that I was training with in Tanzania, and we did a really low cost task trainer for the E Lynch, which is a uterine compression suture. So in Tanzania, They don't have the same resources we have in the US. They don't have uterine tamponade balloons and things like that. So if a patient starts bleeding heavily, really their only option to stop the bleeding is to move pretty quickly to a hysterectomy. Well, fortunately, there's an intermediary step. You can kind of tie off the uterine arteries and try to stem the bleeding that way. But in really refractive cases of postpartum hemorrhage due to atony, there's also uterine compression sutures. And so they were not very familiar with this technique. And I was like, hey, while you're waiting to do your hysterectomy, we can learn how to do a suture. This just takes a chromic stitch, which is inexpensive and available, and we can potentially prevent people from needing a hysterectomy. So this is us practicing, and this is a fairly low-tech model that I just made. I kind of sewed a uterine pillow and stapled it to a wooden base, and then filled it with stuffing, batting, and we were able to practice our V-Lynch sutures on a very low-cost model and practice that skill. So I want to thank you for listening to my talk today. I hope you learned a little something about some of the technology that is available. And if you have any questions, I'd be certainly happy to answer them. Thanks again and have a great day.